Next speaker, Dr. Ashish Nagpal, who will be talking to us about donor preparation for DMEK.
Okay, very good afternoon. Good afternoon, everybody, and thank you, Rishi, for having me here in this course. I think you've been running this course since 2019, and just for the information here, we are the dummies. We are still learning. Every year we come here and we learn something and go back from each other, and it's also very interesting. Rishi keeps rotating the talk, so we keep changing our talks as well. It's not been the same, which makes it more interesting. So this time I got to talk about donor preparation, and I think Rishi has made a lot of my job much easier. I think there is some glitch over here.
While scoring can be done in the chamber.
I'll skip this. I think one important question which arises is where to prepare the DMEK donor, which for most of us in India, I think it's an easy answer that we have to do it ourselves in the operation theatre. Very few of us have the luxury of eye banks who have trained eye bank technicians who can prepare the tissue in advance for you. So that makes it our responsibility. We have to learn how to harvest the tissue. And when we have to learn how to harvest the tissue, the important question is when to prepare it. Because especially in the initial stages, if you're doing it on the same day as the surgery, there's going to be a lot of stress. There are very high chances of tissue loss. They say that almost 5 to 20% tissue loss occurs in the hands of ophthalmics and corneal surgeons. And you will also need a backup tissue. So I suggest, at least in the initial 20-25 cases that you're doing, it would be a good idea after you've finished the wet lab. This is after you have practiced doing it. You should maybe prepare it a day in advance so that you have that peace of mind and less stress. If not, you can prepare it in the morning or before and then plan out the patient. So this is just to get a perspective of when to do it. Instrumentation has been very nicely covered. I'll just keep talking about it as we discuss. The more important part is how to prepare. And in this, fortunately, we do not need a very large corneoscleral rim like in a DSEK tissue. So from the eye bank, even if you have a smaller, thinner scleral rim, that's okay, because we won't be using the artificial anterior chamber. This is just, I wanted to highlight that you should measure, it's not necessary to measure the donor, but it's a good idea to have an idea of the corneal diameter of the recipient, so that it's easy, because in this scenario you will be preparing it much in advance, so it's a good idea to have and plan the sizing in advance. So this was one concept which probably in early 2008-9, when everybody was struggling how to prepare, I think Dr. Art Gibble realized that we need to do a few things. Simple thing was to do this donor dissection inside the fluid medium, and he called it the submerged cornea using backgrounds away, attractively called as the scuba technique. And I think all of us tend to use a mix of it, because you do need fluid, because the membrane is very subtle, very fluid, very thin, so you cannot just keep it dry, and plus you may further damage the endothelium as well. So this is the most important thing which probably changed how we started dissecting. So a lot of surgeons use a mix of it. You don't actually need to do it in the way which has been described, and it's available on the YouTube. If you look for it, the scuba technique, it's over there. And last night when I was preparing, looking at my videos and preparing, so what to show, to break down the steps of the preparation, and I came across Dr. Fogler's beautiful video on YouTube. I texted him that can I use this video tomorrow, and I took off all my, because this is very beautifully highlighted, all the steps. I've tried to break it down. So we'll just go through it. I think the first part is to place it on a cornel, on any trephination block. In this case, they are using the coronet, but you can use any one, whatever you prefer. And the idea is to keep the lower dry. This is first thing you're going to do is do a peripheral punch, which can vary from 9.5 to 10 usually. And as Rishi described it, this is just a partial punch. This is just to kind of mark the, to kind of have a nice edge which we can lift up. Because the other technique which Rishi had described was the Mellis technique, which is the no-touch technique, in which they go from the trabecular meshwork, which sometimes is very difficult to learn and reproduce. So this is a much simpler thing to start off with. And once you have done that, you need to put some trypan blue, because otherwise you can't see anything. So this is purely just for a few seconds, just to stain the edge. This will not stain the desmase as such, unless there is a damage to the endothelium. And once this is done, then you can just drain the fluid out, drain the trypan blue, put some BSS again, and then you start with the Sinski. Sorry, first I think this is a good idea. First is to remove the peripheral DM rim, because that gives you an idea of the behavior of the DM membrane. So once you remove the peripheral rim outside of the donor, then you can start off with lifting the edge. The important thing is to make sure that the edge is equally lifted all around. Sometimes you may go deeper inside if you punch it too hard. If you have a sharp, if you use something very sharp, it may go into the stroma. If you have something too broad, it may not do the job. So that is where you have to strike a balance in finding the right kind of Sinski. And once you have removed the peripheral rim, I'll skip to the next part. In this case, Dr. Fogla is using the one of his DM stripping hook, which he has designed himself, to just lift the edge all around. This is to ensure that the edge is lifted all around, like you would also do in a capsular excis. But this is to ensure that you do not have any radial tears, because if it is attached somewhere, then when you are pulling on it, you may cause a tear. I'll show some videos of it later. So once you've done this 360 degrees all around, then you can take a forceps of your choice, like the one which Rishi had showed, which is a broad edge. I'll skip to that part over here. In this case, he's using a curved tying forceps. This is a good compromise, because sometimes in the other forceps you need to hold it perpendicular, which sometimes we are not used to, and it's difficult, it comes in the way. So it's a good idea to use, it's simpler for me at least to use a tying instead of a straight forceps, because it gives you some more edge to hold on to. And then you can just pull on it. This is so, I mean, this is so beautifully done. It comes out so gently in Dr. Fogla's hands here. And once you have done it, you just peel around 70 or 80% of it, and you leave it there. And then you start with the second trypan blue stain. So you have to stain again the second time now. This time this will be used, this will stain some of the desmase which has been peeled off. So this again is for a short time. You don't need to do it for a long duration. And then you can drain it off, making sure you do not touch. This is an important step. I feel that you can just tilt the trephine so that you just drain the fluid out, because sometimes we tend to maneuver, we keep putting the sponge, trying to drain it, putting some BSS, and that's quite a struggle and maybe causing a lot of damage. So this is a subtle tip which Dr. Fogla has shown, and just to bend it over and drain it all out. And now we are making the stromal punch for the mark, which also Rishi had shown. So you can just use a dermal trephine or a keratoprosthesis trephine. In Dr. Fogla's hands, I think it's working very efficiently. In my hands, I have to hold it, the tissue, make sure it doesn't damage and you have to keep it a little dry so that the desmase doesn't come into the way. So these few things, there is a little struggle at this point, but you need to hold the tissue. Sometimes you can also ask your assistant if you are not able to hold it from the other edge, making sure they do not damage the desmase. And once you have the trifine, you have made a small window. Now what you need to do is float the peeled DM back. So in this, sometimes you just need to put some fluid, and you can put a sponge on the opposite end, which will, with the help of surface tension, kind of flatten the DM. So you can see it's partially strained. The 1/3 of it is not stained because it is still attached. And now once you have done this, you can flip the whole tissue upside down on the same trifine edge, on the same trifine that you are using. And once you have flipped it, you just need to open the window and dry the edge very gently from the sides. Here I would suggest to use not a very dry sponge, use a slightly wet sponge, not a completely dry. And then you can make a mark. In this case, Dr. Fogla is using the Sinski itself to create an F mark. So once that is done, people prefer different. Somebody uses an S. I think Siddharthan uses an L. So everybody can choose their own alphabet, whatever works for them. And once that is done, you can turn it back again with the endothelial side up and do a partial punch again with your required diameter. Either it could be 8, 8.5 usually for most cases. And again, in this case, you don't need to do a full thickness punch, but one can. I mean, if that happens, that is also okay. But then tissue management would be a little more difficult. So if all of the base remains attached, it's usually easier. And especially more so if you are going to use the tissue the next day, it makes it much more simpler. And again, you remove the peripheral donor rim. And then you can just hold it from the edge and leave it there. There is some BSS there, and now you need to stain it the third time, which will be for at least a minute or a minute and a half, because now especially if you are going to use the tissue right away. If you are not, then you can leave it as such. You can stain it just before the starting of the surgery. So this is, and towards the end, once it's stained, it's the tricky part. And I think everybody has their own donor, the glass tubes. There are many kinds available. It will be difficult to discuss all of them. But one thing here is just to pick the tissue up and put it in the Petri dish. And then you can load it from the broader side. And here, this is a very interesting maneuver Dr. Fogla has innovated, in which he takes it in the broader edge and then he moves the fluid to and fro, which helps it to create a double scroll. There is a warning here that it may not work in your hands always. We need to still reach that level of efficiency, but this seems to be the most what I would say, what I feel is least destructive procedure. It seems to just do it. It's a closed chamber. You're just handling the tissue there instead of struggling in the Petri dish. So this is the ideal way, which I wanted to show, that if everything worked out, this is how probably we would have a donor preparation. The other variation sometimes one can do is that if you don't want to use trypan blue, some people mark the trifine with the marker and then put it so that you can still see the trifine edge. So there is some visibility to it. But sometimes there are some particles which come in the way. You either need to keep it more dry. So that again is not ideal, but that can also be done to improve the visibility. And then again, in this case, as I'm using, what I wanted to highlight was never use the Sinski in a slanting way. Always keep it perpendicular to the cornea so that you get a good cut. Because sometimes we tend to use in a slanting way and that doesn't work. And I think this is, I think Dr. Fogla published this the next year in IJO. It's available, the video and this device. I think this device helps in improving the visibility, and they had done a small study to see how it works in the hands of experienced surgeons versus learners. And you can see it utilizes basically the same retro glow what we do in case of a Rexis. So it may help in improving visualization and also in the stripping, because sometimes there may be some tags, some fibrous parts which you may be able to see at least in your learning phase before you can see the indirect evidence, the signs of it. So I think if it's commercially available, it would be useful. The other way to mark it is to use a F stamp or a S stamp, which is again a fairly simple thing to do instead of using a Sinsky. And this is what sometimes you may have a tear right in the center when you're pulling, because each Descemet's membrane, depending on the age, would be different. They would have different fibrous adhesions. So this is sometimes you may have breaks which may ruin the tissue. So you need to be very careful when you're pulling. It is not always as easy as it looked in the ideal one. This is an old video in which earlier sometimes we used to load the tissue from the narrow end. So there will be a lot of struggle before we realized that it's simpler to do it from the other side, which was so logical, but somehow we just didn't think of it at that time. So sometimes this is a thicker membrane. The scroll, it creates a very tight scroll, but still it doesn't go, and it's quite a struggle, and you're obviously damaging the endothelium all the time because it's outside. So it's always not so easy. The other variation is in which the DM will not scroll. It is going to be very adamant, very stubborn. It will keep opening back again and again, whatever the hell you do. So I mean, sometimes what I suggest is on all these, usually we used to do the maneuvers in the deeper part of the petri dish, because as it comes to the surface, they tend to open up. As it goes lower, you can manipulate the same scuba technique probably. But again, this I think probably will be discussed by some of our faculty on how to manage. And I think I'll end over here. I think time is up. Yeah.
Yes.
Thank you. I think we'll discuss the rest as we go. Thank you. Thank you.
Thank you, Ashish, for that wonderful talk. I think the videos were lovely and you covered the topic beautifully.